Hi, I'm Nathalie Moise, a faculty member at Columbia University Medical Center. Today I'm going to be focusing on an applied example for selecting and operationalizing implementation strategies with a focus on collaborative care programs and behavioral health IT interventions. So, the premise of implementation science is that evidence-based interventions aren't translated into practice on their own. They require implementation strategies to improve implementation outcomes like fidelity, acceptability, and sustainability. But how do you identify the right implementation strategy for your program? There's increasingly been a movement towards defining implementation strategies as an integrated set, bundle, or package of discrete implementation interventions, ideally selected to address specific identified barriers to implementation success. Taxonomies like those put forth by the ERIC project now offer a shared language around implementation strategies. A few frequently used ERIC strategies include education, incentives, and audit and feedback. Recently, there has also been a movement towards better specifying these strategies. For example, what does creating an implementation team entail? So Perry et al. Define and specify creating implementation teams as involving the development and support of teams of not just clinicians, but staff, patients, and other stakeholders who are implementing or who may be users of an innovation. This involves providing protected time for teams to reflect on progress, share lessons learned, and make refinements to plan and support one another's learning. Other resources like the EPOC Review Group have proposed systematic reviews of educational, behavioral, financial, and organizational interventions for improving health professional practice. Effective implementation strategies in healthcare include financial incentives, educational programs, and organizational policy. You can also ask more specific questions. For example, what's the best way to give providers reminders? One systematic review found that computer-generated reminders to providers via paper was effective in improving quality and compliance. So how do you select the right implementation strategy for your program? The first step always involves conducting a needs assessment of factors influencing implementation processes and outcomes, and also identifying barriers and facilitators to the implementation of your program. Several methods have recently been proposed to improve the rigor by which we match implementation strategies to barriers. I won't spend too much time on this, but Powell and his group have proposed several methods, including intervention mapping, a 5-step process that draws upon mixed methods research, theory, community stakeholder input, and a systematic process for intervention development. Conjoint analysis, which I've also utilized, a method where you can measure stakeholders' preferences for product and program attributes and learn how changes in those attributes would influence demand. This also allows you to forecast the acceptability of potential implementation strategies in the real world. Group model building has also been employed more recently, and this is particularly great for dynamically complex problems. It involves engaging stakeholders to develop causal loop diagrams. And then finally, concept mapping. So this is a participatory approach which involves brainstorming and creating visual maps of concepts rated on certain dimensions, like feasibility of a given implementation strategy. Other methods have also been proposed, such as stakeholder interviews, Delphi polls, modified Delphi polls as well. And so really the key piece that I'm leaving you here with is that you need to do a needs assessment. And then there are lots of different methods by which you can map specific strategies to the barriers to implementing your program. Increasingly, I've used something called a behavioral change wheel framework proposed by Michi et al. This really forces you to really focus on one behavior and to understand the constructs of that behavior. So is that behavior driven mostly by capability, which is knowledge, opportunity, time, resources, motivation, which is self-efficacy, or a compilation of all of these? The next step is then to map intervention functions seeped in behavioral change theory and also policy categories to those constructs before identifying behavioral change techniques, which then map to those intervention functions. systems. Mitchie et al. Proposes that use something called the APPEASE criteria, which includes acceptability, practicality, efficaciousness of a given behavioral change technique. So if your behavioral change technique meets all of those criteria, you can then say that this is probably the most feasible behavioral change technique for addressing the construct of a given behavior. The last step is identifying content and implementation options for a given process, which also includes the mode of delivery. So now that we know a little bit about implementation strategies and how to operationalize implementation strategies and select the right implementation strategies for your given set of barriers to implementation, let's focus on an example. So collaborative care is a program that's been around for quite some time. And so this program incorporates care managers who collaborate with psychiatric consults to provide stepped depression care in primary care clinics. This program has been shown to be effective in improving depressive symptoms and other clinical outcomes in more than 100 clinical trials. While there are a lot of barriers and facilitators to implementing these programs are increasingly being implemented and scaled up and more recently sustained across the country. Often in real-world settings, programs have already been partially implemented or entering the sustainability phase. I'm going to demonstrate how you can conduct a needs assessment to improve the uptake and fidelity long-term of a program, especially if that program has already been partially implemented or is entering the sustainability phase. As part of an OMH, which is Office of Mental Health Policy Scholar Grant, I work with colleagues to assess the implementation, scale-up, and sustainability processes of collaborative care across New York State. Using strategies like technical assistance, training, incentives in the forms of grants, and audit and feedback, the state successfully implemented collaborative care in 32 clinics across New York State. And so this was actually quite effective. They improved screening, they improved clinical outcomes in these clinics across the state. The state scaled up this program in more than 150 clinics in 2015, and more recently we're nearing 200 clinics. And they provided financial incentives in the form of fee for quality for reimbursement infrastructures. Where clinics can bill for enrolled patients per member per month. So in 2016, a colleague and I set forth to conduct a needs assessment of the original 32 clinics to ascertain implementation processes and identify barriers and facilitators to long-term fidelity of these programs. The first step in any needs assessment is to look at quantitative outcomes and to really quantify the fidelity of a program. So we found that the percent of individuals screened actually remained consistently high in the sustainability phase. So this is 4 to 6 years after implementation. We also found that the percent of individuals with at least 3 contacts who are in the program also continued to improve over time, as did the improvement rates in depressive symptoms. Other fidelity metrics like percent of individuals with a psychiatric consultation, the percent of individuals who had some kind of treatment change in the last couple months also continued to improve. The one measure that appeared to deteriorate was the number of patients who actually enrolled in the program. This did not appear to align with the number of newly diagnosed depressed patients. So that number stayed persistently elevated. However, the number of patients who enrolled in the program continued to fall 2 years into the sustainability phase. The next step is to identify qualitative measures around barriers. We found that barriers such as knowledge, funding, IT registry upkeep were less likely to be mentioned in the sustainability phase, whereas resources, personnel, and behavior, namely provider and patient engagement, appear to be persistent barriers long term. Many providers didn't think that patients were depressed or had a hard time buying into the program long term. We saw patient level barriers in the form of stigma and motivation, and then systems level barriers that involved managing referrals, triaging patients, and engaging patients, which remain key challenges long term. The next step is to create a logic model, which really allows you to understand some of the objectives of a program. So we found that there were key inputs here from the state's perspective. We needed staff to kind of oversee the collection of metrics, time, resources, billing infrastructure were all inputs that were technical assistance as well, were all inputs that were needed to kind of implement these programs. And key activities included enrolling clinics, going through the billing process, collecting metrics and feeding those back to clinics, for example, screening rates at the clinic level and across all clinics enrolled in the program, online and in-person collaborative care training, and then again, this kind of measurement-based reimbursement infrastructure. So the short-term impact from a process and fidelity perspective was to improve the number of patients who were being screened for depression, ensure that there were weekly multidisciplinary rounds between providers, psychiatrists, and care managers. And then another key construct was to increase the number of patients who were enrolled, which allowed clinics to bill for these programs and to sustain these programs long-term. So we realized that a key construct here, a key objective of these programs were to improve the show rates, improve the number of patients who could enroll in these programs, which would allow these clinics to bill and sustain themselves. Other key medium-term impacts were to improve the clinical outcomes. It was very clear that once patients made it into these programs, their clinical outcomes in terms of their depressive symptoms actually improved similar to the original trials. So it was quite clear that the process around which collaborative care was being implemented in the long run was actually working. So fidelity was quite high. The key construct that appeared to kind of deteriorate over time was the enrollment, which happened to be key to sustainability. So creating a logic model really allows you to kind of understand some of the objectives of a program and then to align your implementation strategy with those objectives. The next step is to identify a theoretical framework. And so we chose the behavioral change wheel framework to help identify an implementation strategy that would address the low enrollment rates in these clinics. And the first step was to identify a key target behavior. Because patient enrollment was a key behavior tied to sustainability, we identified that as the key behavior that we would try to understand and explore. The next step is to really try to understand some of the constructs of that behavior. To what degree is capability, opportunity, and motivation affecting patient enrollment in collaborative care programs? The next step is then to, again, map intervention functions, policy categories, and behavioral change techniques to those constructs before identifying content and implementation outcomes, all using, again, the APPEASE criteria to find the most feasible implementation strategies to improve the uptake of your program, here collaborative care. So we often find that after an initial needs assessment, it's often necessary to go back to other stakeholders, such as patients and national experts, to ascertain the generalizability of these barriers and to map the constructs of your selected behavior. Literature reviews can also assist in identifying potential evidence-based strategies as well. So it was clear from our mixed methods process across New York State that the key behavior is patient engagement and billing. So we conducted 12 patient focus groups and 10 national expert interviews and further kind of delved into some of the constructs at the patient level, which included knowledge, preference, shame, cost. And the experts allowed us to really focus on multi-level factors leading to low patient engagement, which included patient motivation and literacy, provider knowledge and comfort treating depression, and then also inadequate screening and diagnostic systems, which all contribute to low enrollment rates. Finally, our systematic review identified treatment preference matching, motivational interviewing, and coordination as key strategies for improving the uptake of depression care in primary care settings at the patient level. So after we ascertain some barriers at the patient, provider, and systems level, we then categorize these barriers into capability, opportunity, and motivational constructs. For example, language and literacy or lack of knowledge about collaborative care fit into the patient level capability issues. However, complex billing systems and long wait times were opportunity level barriers at the systems level. These then map to several intervention functions and behavioral change techniques. We used a group of end users to refine this list and only selected those intervention functions and behavioral change techniques thought to be feasible according to the APEA's criteria. There are over 100 behavioral change technique taxonomies, and we were able to select only a handful of key techniques using this process. Other methods for selecting behavioral change techniques might be modified Delphi polls or stakeholder interviews as well. To further refine our strategies, we determined which ERIC strategies overlapped with our behavioral change techniques and found that most were at the provider and systems level. This really allowed us to understand the ways in which using multiple methods allows you to create the most effective, multi-faceted implementation strategy possible. So by combining the BCW and ERIC strategies, we're able to create an intervention that not only met patient level goals, but also provider and system level goals as well. So, for example, developing educational materials, reminding clinicians through clinical decision support, and also computer generated reminders on paper were all strategies that tied in very nicely with the behavioral change techniques at the provider level. Assessing and redesigning workflow was another ERIC strategy that also we thought would address long wait times and the complex billing infrastructure. Finally, we specified our implementation strategy and determined that technology and tablets would be the best mode of delivery for all of our behavioral change techniques at the patient level. So this might include motivational stories, preference and value assessment, connection to online treatment resources to address some of the time and resource limitations. We also determined that training sessions, EMR prompts, and paper preference reports to providers with an option to bypass the provider completely via the tool to connect patients directly to care managers would also address some of the provider level barriers. Finally, we felt that creating education and best practices for billing infrastructures, educating on effective solutions to long wait times, and then leveraging the iPad to facilitate screening and a referral system would also be the best systems level modes of delivery for delivering our behavioral change techniques at the systems level. Finally, the last step really is to identify the content and implementation options. We created a tool that would screen, activate, and connect patients to treatment while also giving providers a patient preference report, which would allow us to remind providers in real time to focus on depression and to participate in more patient-centered communication strategies. We then used ERIC to select multi-level strategies that were feasible and would address multiple levels simultaneously. In order to organize implementation teams, use evaluative and iterative strategies, and continuously obtain and use patient and consumer and family feedback, we created mini teams of creatives, intervention development individuals, which included physicians, patients, and care managers, an advisory board of behavioral and implementation experts, and sets of patients to user test our intervention, which would allow us to rigorously tailor our intervention over time and operationalize these strategies. I'm Nathalie Moise, a faculty member at Columbia University Medical Center. Thank you for joining me.